مساء النور. ازيكم؟ يا رب كلكم تكونوا بخير. انا دكتور نوري عادل، اخصائي جراحة الفم والوجه والفكين، ومدرس مساعد في قسم جراحة الفم والوجه والفكين بجامعة مصر للعلوم والتكنولوجيا، وowner and founder of Cosmetico facial and dental beauty. النهارده انا عندي ضيفة مميزة جدا 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 جدا، دكتور سابرينا شاه-Desai. She is a leading aesthetic reconstructive OculoPlastic surgeon based in United Kingdom. She is also a member of the British OculoPlastic Surgery Society and Interspeciality member of British Association of Plastic Reconstructive Surgery. She is a call for Sinclair and Teoxane and an ex-call for Galderma. She is also multi-award winning and she runs a Cadaver training academy of OFA. مساء النور يا دكتور أنس ومساء النور يا دكتورة نسرين. Okay, I'm shall add you right now. Okay. I'm right now. She's supposed. Okay.
Hello.
I'm glad that you found your way.
I know this is my first Facebook Live, so I'm very, very excited.
It's my honor to be the first one to interview in this first live webinar of yours. I was making the introduction. First of all, thank you so much for your time and for your effort and to indulge us with this webinar. I guess there is a little bit of sound delay, so I'm going to ask you the question. You're going to wait for a couple of seconds and give your answer. Thank you for being with us in this webinar, Dr. Sabrina. I made the introduction. Actually, it was a pretty long introduction, and I would probably need a lot of more of hours to speak about your career and your profession, your long journey in this specialty. So let's first talk. As an oculoplastic surgeon, you know very well that eye reflects age more than any other part in the body. And to fully understand aging, you have to properly look at the young ideal eyelids of teens. And you know, the eye shadow space and such things. Some people tend to hide the early signs of aging with the use of makeup. Sometimes it works, sometimes it doesn't. So tell me more about periorbital aging.
Okay, so the first thing is that, you know, a lot of people say that they've developed a tear trough deformity. But I want to explain what a tear trough is. So a tear trough extends from the inner corner of the eye, which is the medial canthus. It runs along the bone up to, you know, the medial limbal line or the mid-pupillary line, okay? And so this is the true tear trough area. Then you have a hollow, you know, lateral from the mid-pupillary line up to the outer corner of the eye. This is called the palpebromalar groove, okay? And then you have another groove which, you know, ages the under eye area. It's actually the mid-cheek groove, okay? Now, you know, people get confused between the nasojugal groove, the tear trough, and the mid-cheek groove. So the nasojugal groove lies just below the tear trough. And as we age, it almost extends and becomes one with the mid-cheek groove, okay? So I've actually got my skull. I've got Stanley with me to show you.
I have seen him on your YouTube videos.
Excellent. So to show you that that's the eye socket in which, you know, the eyeball sits. But in green is the tear trough. So exactly what I showed you, you know, on my under eye area is actually on the bone, okay? This is the tear trough ligament. And what happens is that when you're born, you have that ligament, but the ligament is not as obvious in most Caucasians. However, in Indian ethnicity, in Hispanic ethnicity, and even in Afro-Caribbean and certain Asian children, you can see an under eye hollow. You can see a dark circle, and you can see a depression under the eye. So actually, certain ethnicities develop an under eye hollow very early in life. And again, you know, the Middle Eastern population, Far East Asian population, the Asian, Indian, Pakistani population, and the Hispanic population.
So let's say it's like there's no actual causes that may promote the aging for the tear trough area. Instead, they may be caused by certain hereditary factors or genetic factors. So it may be something that appear in teenagers instead of like there are certain cause effect. But of course, there are some things that exaggerate the aging of the tear trough. Okay,
Yes.
I want to just ask about something. You said that the nasojugal groove is not the not the mid-shake groove, because some people claim that they are a single structure.
So, as you get older, they amalgamate and can become a single structure. But where it is on this inner side, there are two distinct structures. Okay. So you have the tear trough hollow, and the lower border of the tear trough, the lower border is the nasojugal groove. And actually, all the vascular anatomy, the key vascular anatomy lies in the nasojugal groove. So this is your facial artery, your facial vein, which becomes, obviously, it's called the angular artery and the angular vein. They lie in this nasojugal groove.
So speaking more about anatomy, we have like three key or three main ligaments in the tear trough area. We have the ORL, the tear trough ligaments, the zygomaticocutaneous ligament. Could you tell us more about it and its clinical significance when you do a filler injection?
Exactly. So here's
I'm gonna steal Stanley at the end of this webinar.
Steal Stanley. Stanley is my favorite. When I do cadaver labs, I have a Mabel and I have a Stanley. They're very English names. Okay. So the tear trough ligament. And anatomically, this is really important because it is actually, if you think about it, a condensation of the ORL, which is in black, okay, the orbital or the orbicularis retaining ligament. It's actually the orbicularis retaining ligament. And in purple is the zygomaticocutaneous ligament. And these two meet and they condense into this dense fibrous band at the tear trough. Now, this is the orbicularis oculi muscle. Okay, so it is like a cap that sits on your eye socket. It's a flat muscle and it is connected to the bone by these ligaments. Okay, now the ORL is actually, it's like a baklava. The orbicularis retaining ligament is layered
and it has a lateral thickening at the lateral part of the eye.
At the lateral. So just think it's like a stacked little phyllo pastry. Okay, I love food like you, Noury. So I was looking at what you enjoy doing, and like you, I love travel and food. So all my analogies are very much related to food. But on this side, this ORL, okay, this ORL is like a phyllo pastry. It's stacked. So the interesting thing is when you put filler in from your mid-pupillary line outwards to your lateral canthus, this is a very forgiving part of the under eye area, okay? But when you put filler over the true tear trough, it is not forgiving at all. And this is where you need to be really careful and you really need to, undertreat. You need to use a proper filler that has been developed for treating the under eye. And particularly when the skin is thin or there is quite a large fat bulge, you need to be very careful because, one size doesn't fit all. Definitely in the tear trough, it doesn't fit all. Okay?
Yeah. When we speak about the face, you know that faces consist of 5 layers, but in the tear trough area, we have a special, it's a special curtain area. The skin is highly adherent to the muscle and to the underlying periosteum. How this may affect the modality of treatment that you are using to treat a tear trough.
So this is where we start understanding facial anatomy.
Want to hear something hilarious? Today I ate a big tasty McDonald's sandwich and a cheeseburger. I think I have an appetite for more.
I love halloumi burger, so I like using this burger analogy. So, if you think of the burger as representing the layers of your face is generally made up of 5 layers. There are some areas of the face, like the temple, like the outer part of your eyelid and the cheek junction, where you have more layers. You have between 7 to 13 layers even. But essentially, if you just think simplistically, of 5 layers. So layer 1 is your skin. Okay. Now in the under eye area, the epidermal area changes. So in skin of color, like you and me, like the sesame seeds of the bun, you'll start getting hyperpigmentation. The texture of the skin changes. So one of the key ways the under eye ages is textural change of the eyelid skin. So I represent this with the sesame seeds of the bun. You get a textural change. Often, I will see little white to yellow dots, thin lines, crepey texture of skin, and then it becomes loose. Okay, so this is the texture. Then the actual thickness of this bun becomes less. So the skin becomes thin and atrophic. Now, generally we see this in Caucasians from the age of 30 plus. But actually, in Indians, they have very thin skin. So there's certain, the Indian dark circle, the skin is very thin, so it's very difficult to treat. Okay? So that is layer 1. So you can see how layer 1 of the face is the key area that's aging in the under eye. It's getting hyperpigmentation.
It has a high impact on the line of treatment.
Very high impact. So you get hyperpigmentation and you get thinning. Okay? And then it will become loose. Layer 2 of the face, or the mayonnaise layer, okay, we actually lose this subcutaneous layer of the face in the under eye area very early in life, as early as your teens. So this layer goes. Now, if you gain weight, this layer may come back in your cheek, but it's not going to come back in your under eye area. Okay? This layer doesn't exist in the true tear trough. So it's there when you're young, but by the time in your teens, it's gone. Okay? Then you have the muscle layer. Now I showed you this muscle. This muscle is the orbicularis oculi muscle, right? And this muscle is moving 16 times a minute. And it's a very thin, flat muscle. See how thin and flat it is. And it's got, if you look at this, and I put it on my eye, the light pink is the bit that stays within the eye socket, and the dark pink is the orbital bit that goes beyond the bony rim. Okay? And they both have different functions. Now, this muscle layer, because it's contracting so many times, as we get older, when it loses its padding on top and it loses its padding on the bottom, it shows its movement much more. So dynamic movement increases. Okay? So this is your muscle.
But does a hypercontractility in the orbicularis oculi may affect or exaggerate those steps?
May affect or exaggerate?
Yeah. If the orbicularis oculi muscle have a hypercontractility?
Yes, yes. When you lose the padding on top and at the bottom. Okay. And then finally, deep fat layer, which is the cheese layer of your burger over the bone. Now, this deep fat layer is really important because in the under eye layer, it's called the SOOF, okay? The suborbicularis oculi fat pad. Okay, now you can see I put it in between the zygomatic cutaneous ligament and the ORL. This is your key injection point when you start treating the tear trough. So whether you are a novice or whether you're an advanced injector, injecting here gives you the biggest bang for your buck. This is your SOOF, or the suborbicularis oculi fat pad. What does that mean? It means it lies below the orbicularis oculi muscle. So you have skin, subcutaneous fat, orbicularis oculi muscle, then you have deep fat straight on the bone. Now, if you and I feel our bone here, okay, you can only feel skin, muscle, maybe filler if you've had filler, and bone. That's it. You don't have that. This. Okay, you're naturally good looking, and then you have lateral SOOF. Okay, so you have the medial SOOF, the lateral SOOF. So if you look at it, the medial SOOF runs from the medial limbal or the mid-pupillary line up to the lateral limbal line, and then from the lateral limbal line to the lateral canthus, you have the lateral SOOF. Okay, so these are key areas.
Some people and some clinicians do cross this area when they do the injection, and I have seen this a lot. Yes. And they even use cannula. They think that this is probably more safe but still there's a risk.
So a cannula is relatively safe. You have to cross this area to treat the true tear trough. And I would say to you that, this is where intermediate injectors should be. They should be injecting the medial and lateral SOOF. This is where advanced injectors inject. And we didn't finish the deep medial cheek fat pad, okay? Which is an indirect way of affecting the tear trough, because when you inject or push this deep medial fat pad, it supports, you can see the ORL and the lower border of the tear trough ligament. So this deep medial fat pad is one of the key areas you will treat in somebody who is showing a mid-cheek groove. And generally you start seeing that after the age of 35. Now, this is the injection area deep on the bone, targeting the deep medial cheek fat pad for basic injectors who want to indirectly improve the tear trough. This is for intermediate injectors, the medial and the lateral SOOF. And actually injecting the true tear trough is for advanced injectors. Okay?
Doctor, when do you decide to treat the tear trough area, and when do you decide to go on for a temple and cheek filler in order to enhance the tear trough? It's whether you choose to go directly or indirectly.
Okay, so
depending on what you choose the approach.
If you have a large bag and you have a mid-facial descent and deflation, that means you have a mid-cheek groove, you've lost the Ogi curve, and you have to look at the face in side profile and in lateral gaze. And if you've lost this anterior cheek projection, the lateral cheek projection, and you have a hollow that extends beyond the lid cheek junction into the cheek, then, and you have a hollow temple, then actually indirectly addressing these areas, that is the temple and the deep medial cheek fat pad and the line of ligaments, even the lateral SOOF, is a beautiful way of treating a reasonably large bag, a moderate sized bag, and a hollow. So if somebody, generally I would use this treatment if somebody has a moderate sized bag and a hollow, and you generally use these indirect methods for the older patient who's got a lot of facial volume loss. But if somebody comes to you in their 20s and 30s, often this is a congenital or a hereditary or an ethnic under eye hollow. And generally that is not associated with the kind of aging changes you see. And generally just by injecting either the SOOF or the true tear trough area, you get a good result.
Doctor, concerning SOOF, it's like, as if you are explaining your rituated videos, it's like this, a superficial part and a deep part, and in between there's a malar ligament.
Yes.
Which part of the SOOF you should be targeting, and what kind of complication or risk may happen if you inject it improperly as a SOOF?
Yeah, so very good question, Noury. So you can see that the SOOF is what I've shown you here, and it's this whole area over here. Now, the superficial part of the SOOF is where the eyelid lymphatics lie. So if you are lying, or your needle or your cannula is superficial, and you deposit the filler superficially, or you're very rough with your cannula and you damage these eyelid lymphatics, you will end up giving the patient malar edema, malar mounds, festoons eventually. So you always want to inject deep on the bone. Yeah, you don't want to inject superficially in the SOOF at all. Because of the malar septum, you want to stay deep to the malar septum.
Okay. When can you decide to do the sandwich technique by placing a filler on the periosal level and placing another filler on the subcutaneous level, like building it? How can we apply this, and when we can decide to do such a technique?
Eye boost. This is what I use very often, and I would use it primarily for ethnic dark circles with very thin skin, because I'm using a very thin skin boosting filler injected in mesotherapy fashion to plump and hydrate the skin. Now, what happens is when you actually inject in the true tear trough area, cadaveric studies have shown that because of the way the muscle is around this, because remember, there's only skin, ligament, the muscle on either side, and the bone. Okay? So the muscle is actually adherent to the bone. And when you inject in this area, even though you are feeling the bone and injecting on the bone, the filler ends up lying superficially. So it ends up lying in the intramuscular and then the subcutaneous plane. So it may not do that immediately, but it does that over time. So therefore, you need to inject very low quantity. You need to be sure about the rheology of the product. You need a very, very soft filler. You don't really need a high G prime filler. You want to use something that's not particulate because you want to avoid tyndall, and you want to use very low volume. So think of progressive treatments for treating the tear trough.
And also the soup has a high surface volume coefficient. Whenever you place a filler, it has a high tendency to disperse other than areas in the face. I guess the same occur in the forehead when we do a filler in the forehead too.
Yes. So one of the tricks I have, and the key point to inject is this point, okay? Now, if I were to show it to you clinically, it would be the point.
Sorry, I didn't see the skull. Could you bring
Okay.
it closer to the camera? Okay.
Okay. So basically, the point to inject is where your tear trough ligament meets the ORL and the zygomatic ligament, which you can't see. I'll take out here. Okay. So when you inject, yes. So if I were to show it to you, between the medial limbal line and the mid-pupillary line. So you're going, in that zone. That is the sweet spot. If you inject there, you can massage the filler. You just press the filler and the filler goes on either side. And the filler I love using in that area is Redensity 2. It's the only filler that's licensed for the tear trough. It has antioxidant cocktails that are going to help with the metabolic capacity of that area, and it's going to help with the dark circles. So I love using Redensity 2. It's part cross-link, part uncross-link, so it doesn't absorb as much water. So the hygroscopy is low. So it's already pre-soaked, so it causes less swelling. So I like using.
Do you also look for a filler with a low HA concentration below 20 milligram per ml, or it doesn't differ to you?
Yeah, I like using low HA concentration.
Okay. What's your opinion about Politero or Perfecta?
So I would not use Perfecta in this area because it has a very high G, but of course there is fine lines, Perfecta fine lines, which has a low G, and it almost behaves like Vital Light, so you could. Bellatero Balance is lovely because it has great dermal integration. I have played with all fillers in the under eye area, okay? Bellatero Balance, Volbella, Bellatero Soft, Restylane Vital Light, Restylane Refine, Redensity 2. So you could see I played with a whole lot of them. At the end of the day, you have to tell your patient why you are particularly choosing a filler in the under eye area, and you have to convince yourself and your patient why you are going to use a filler that is not licensed for use in the tear trough. Because if you have a complication, medico-legally, the first question is going to be, what was the filler you used and why did you use the filler in this area?
Exactly. Doctor, what is your own point of view about injecting botulinum toxin in a hypercontractile orbicularis oculi in like a microdroplet technique or whatever technique? Does this may yield or may worsen a tear trough or may even give a tear trough problem? Like doing a paralysis for the orbicularis oculi muscle, may this result in creating a deformity if it's done improperly?
So it depends. There are times when it actually helps. Okay. However, if you have an eye bag and you have a lot of laxity and you then also have that orbicularis hypertrophic roll and you put in the toxin. Exactly. And it will worsen the bag. So it will then definitely worsen it. So that's a wrong indication for doing it.
So proper patient assessment and doing all the necessary tests to determine if the patient, which to choose line of treatment. Doctor, do you do any other test rather than the SNAP test?
So I do a lot of tests. The first thing is I will actually examine the skin. So I pull the skin I do a distraction test to see what happens to the color of the skin. I also use a skin analysis camera called Aram Huvis, which is like a mexometer. It tells me what the pigmentation is in that area, because sometimes, you know, the pigment is hidden in the groove and the patients don't see it until you actually put the camera and you have objectively shown them there is hyperpigmentation there. Then I do a test where I get them to look chin down, look up. That shows the full extent of the eye bag. I pull the eyelid and I let it go back. That's the snap test, because I'm checking for how loose the lower eyelid is. If the lower eyelid snaps back without the help of a blink, then the eyelid has good recoil and it'll do well with fillers. When you pinch the skin and you pull it away, the skin doesn't go back, it sits like a fold, and then you need to actually blink like this to push it back, then that's not great, because this is a patient who can potentially swell with filler. And then, I also do this push test to see if by replacing the deep medial cheek fat pad, it improves or supports the tear trough. I look at the face in profile and I look at the positive vector or the negative vector. So I see where the eyeball is sitting in relation to the infraorbital rim.
And I guess what you do with the cheek tracheoderma, is it a pseudo tear trough or a true tear trough? Like a true tear trough will never disappear despite whatever you do with the cheek or try to pull your skin. Dr. Sabrina, tell me, what is your own opinion about energy-based device such as HIFU, Ulthera, Plasmage, Blepharoplasma? Of course, most of our audience are dentists, so they are not familiar with such devices. So please tell them what does those devices do and how can we utilize them?
Basically, let's get back to the burger. You see this textural issue, okay? So with age, although the tear trough loses with volume loss, the age is with volume loss. You have volume loss in the skin, in the subcutaneous tissue, even the muscle gets attenuated, the ORL becomes a little lax, and you lose soothe and you lose bone, okay? So basically there's a volume loss in the under eye. But with it comes a volume excess. There are 3 volume excess. The under eye bag increases, which is the fat inside your eye socket that comes forward. The skin becomes looser, and you can get a malar mound, or which can then become malar edema and a festoon. Okay, so you can get this laxity much lower down and that's called a saddle bag. So you can get eye bags, saddle bags, and the loose skin bag. So this is why the older you get, you need to be able to tighten the skin. Whether you tighten the skin surgically or whether you tighten it non-surgically is the question. So if you are going to tighten the skin non-surgically, and this is actually the ideal way to tackle mild to moderate laxity. If you have moderate to severe laxity, they are surgical candidates. But most of the patients that present to us for non-surgical rejuvenations are mild to moderate generally. Okay? So the whole spectrum of energy-based device, whether you use CO2 laser, YAG, neodymium YAG laser, erbium YAG laser, whether you use Tixel, which is pure natural heat, whether you use radiofrequency microneedling, and my favorite is Morpheus 8, whether you use Ultherapy, they are all, or plasma, nanoplasma, plexer, they are all working on tightening the skin and stimulating collagen. Collagen is a structural protein of the skin, so they're stimulating collagen, they're giving the skin firmness, and they're improving the surface texture. And sometimes this heat, particularly with the radiofrequency microneedling, will also tighten the bag because it pushes back that prolapsed bag because it's tightening the fibrous tissue in front of the bag. So, you cannot treat the under eye area only with filler, only with Botox, or only with surgery. You do need some form of energy-based devices in your armamentarium to treat. Now, Ultherapy, if you have really good thick tissue on your brows, on your eyelid cheek junction, you can have Ultherapy and it can tighten things, okay? But if you have thin skin, which a lot of patients do, then Ultherapy is not such a great option for the eye area. Plasma is great because it gives an instant result, but there's a lot of downtime associated with it. And in the lower eyelid, particularly, plasma can have a downtime of anywhere from 2 weeks to sometimes even a couple of months. In terms of erythema, the scabbing goes away in 10 days. Plasma is very good because it doesn't translate the heat to deeper tissues. So you don't have a risk of dissolving filler. Okay. However, with and it's the same with Tixel because it's a more superficial treatment. So in my
Can you
clinic,
combine a plasma with a filler at the same in
separately.
between
I do them separately. So with plasma, you get a lot of swelling. The tissues just become hugely edematous. So you can't put filler where you're going to get that kind of swelling. So for textural issues, okay, for these textural issues, so the sesame seeds of the bun, I like using Tixel. It's great. I also do transdermal drug delivery with Tixel, so I use it in open channel mode for pigmentation. And I do vitamin C mesotherapy that really helps the under eye. There's virtually no downtime with it. We put numbing cream, we do the treatment. It takes 15-20 minutes to do. They go home and they come back, every couple of weeks and they have that treatment. So there's really no downtime as opposed to the freehand, Napage style injection of mesotherapy, which can bruise quite significantly. So I like using Tixel for texture and for treating pigment with the transdermal drug delivery. I like using radiofrequency Morpheus if you have, that hypertrophic orbicularis roll, if you have like a fold of skin. So the older you get that fold of, muscle and skin when you smile. And that's because the radiofrequency needles go deeper. You can use them in all types of skin colors because they're not heating, the heat is delivered deep, not on the surface of the skin. I've had Morpheus 8. In fact, I just had my Morpheus 8 on Friday. That was my second Morpheus 8. So you can see me. I have, I only have SPF and lipstick on with eyeliner. I don't have any makeup on. Okay. So you can see. Thank you so much. Thank you. But you can see the healing time is very quick. The healing time is very quick. Okay. What happens is because the needles go deep and they actually have a coagulation zone that heats even more than the needle depth. So that's why you can get some of the fat going back. So if I see a bit of an eye bag, I see loose skin, that orbicularis hypertrophic roll, I'll move to Morpheus 8 microneedling because it's deeper. Okay, so that's how I use it. Sorry, yeah, it's all about patient assessment. I don't have a laser. One of the reasons I don't have a laser is because, it's quite painful. These modalities are not that painful. We numb and the patient is very comfortable. Because I'm a big
Doctor, speaking about surgery, you are fully known for your invisible zip stitch technique. So, and I have seen a beautiful cases for you on your Instagram page.
Thank you.
So, tell me more about it.
So basically, it's a way of stitching the eyelid.
It's very advanced for our audience, but it's always good to speak about such techniques.
So basically, when we make a cut, all scars require time to heal. And what I do is I hide the stitch inside the cut. So it's a subcuticular stitch. You can only see the edges. This looks like a zip when you close it. Right? Yes. So I tie it in the crease. And I also under the eyelid where the stitch is hidden in the crease.
And you found that there's no scar, you don't need to do scar revision or go for laser sessions. This technique is like provide no scar, or what is your opinion?
I will never say never because it can, scarring is so individual. I guess 99% of the patients don't have a scar that require thing, but 1% you'll always have that risk and you can have some resurfacing to, handle the scar.
Doctor, speaking about myomodulation and using fillers to alter the muscle activity, is this possible to be applicable in the tear trough area?
100%. So, when you put filler that is down on the bone, what happens is the filler supports this muscle. Okay? The filler moves up through the muscle and it's also on the top. And it definitely dampens the activity. It definitely dampens that hyper mobile dynamic activity. So I do believe that it supports the muscular activity, myomodulates it.
Okay. Do you think it's wise to use filler products that are made of polymers to be injected in the tear trough? It is catastrophic.
I
It's going
use
to be catastrophic.
biostimulatory fillers, but because the tissue is so thin and because it's so close to the surface and there is a mobile muscle on it that's moving constantly, basically one of the key reasons you get these granulomas is intramuscular injections, highly mobile tissue injections. So you would never inject it in the lips, and I don't put it in the tear trough.
Okay. Doctor, you use silhouette soft threads. What is your opinion about using PDO threads and the whole thread system in the eyelid? And you know the trend that we spoke about a couple of minutes ago about the fox eye and such things. What is your own opinion about using these threads?
That Silhouette Soft threads, and I'm a trainer for Silhouette Soft because it has cogs. So I feel its fixation, internal fixation, is much better. I have no experience with PDO, and I do the thread lift to lift up the brow to create that fox eye look. Okay, I don't I don't advocate it. I mean, if you know me, Noury, I'm very minimalistic and I like celebrating people's individual beauty. I don't like creating clones. I understand it's a trend. The thing with trends is you can have a lot of complications, and reversing those trends around the eye
Because
is
you are a facial aesthetic master expert, unlike other clinicians who just are butchers, they are just seeking to do a fake look and they don't care what people might say. Doctor, we have a question here. Sorry to interrupt you before we go on to our question. Someone is asking you, what is your opinion about PLLA threads to support the tear trough or to treat crow's feet?
okay. So again, I don't put them that superficially. I know people do, and they say they have great results. I just use energy-based devices. I don't use PLLA threads.
Okay, we can now go on for our topic. You said you used the red thread.
With long-term studies, I wouldn't want to use it.
Okay. So, doctor, you were speaking about threads and I interrupted you. Could you go on with the subject?
So with fox eyes, it's a combination of putting filler in the temple, putting filler at the tail of the brow. So you can automatically see how this, lifts up, and, then putting a thread to just lift the tail of the brow. Okay. So it works in certain type of people. So certain patients who have thick skin and who have, and again, Egyptian patients, Armenian patients, patients who have that kind of an eye that it will suit their inherent beauty, and they have thick skin will do well. Doesn't do well on Caucasian eyes with thin skin. They don't have that eye shape. And I see so many patients who I have to rectify, I have to correct. And then it's a horrible situation because dissolving filler is easy, but it stretched the skin, getting rid of that thread, and the brow is all pulled in a funny way, is awful. So I would say be very careful, choose your patients correctly, keep in with the ethnic beauty. Again, Egyptian eyes are those beautiful kind of eyes, so yes, your patients would do well with it because they have thick skin, thick brow fat pad, thick subcutaneous tissue, and these are the patients that will suit that look.
Actually, I don't understand the concept of the whole fox eyes. Why would a patient go for a thread from here up to his temple? It's not something like people should do it. But tell me, doctor, what is the dark side behind using facial threads in the periorbital region? What are like the complications that may happen?
Basically, with threads, they can extrude, they can migrate, and they can actually, the barbs in the threads, because there are all types of threads, can actually scar the under eye because the eyelid is so thin. And remember, this muscle is responsible for your blink. It's a functioning eyelid. The eyelid is there to protect your eye. If it's not able to blink properly, I've seen patients with dry eye problems. In fact, I'm doing a webinar on the 9th of July. We're talking about this with corneal surgeons. How cosmetic surgery can go wrong and how it affects the blink. and rectifying this outer corner of the eye, being able to get this muscle to blink properly is very hard, and people end up with awful problems where the eyelids are rolled out, they don't blink properly, they have watery eyes, dry eyes, and chronic pain. So it's not all trends are not straightforward, and you can end up with really serious complications.
I see. Dr. Sabrina, being a call for Sinclair and Teoxane, tell me more about Ellanse. Where do you use it? Where do you recommend it to inject it, to use its benefit? It's a biostimulator, as I assume. We don't have it here in Egypt, by the way.
Sorry, you don't have it in Egypt?
Yeah.
It is fantastic. So Ellanse is a biostimulator, and the vehicle is CMC, it's carboxymethyl cellulose, okay? And it's got a very high G prime. It's got an amazing lifting capacity. And what happens is it produces collagen after 3 months. It actually starts by 6 weeks, but by 3 months, you can start seeing a visible result. And it continues to produce collagen even at 9 months, so that you are seeing a huge longevity from the treatment. I love using Ellanse for the quality of the skin, this peri-oral area, where often, dermal fillers can sometimes cause this to become, unnatural. You can see lumps. You don't see that with the biostimulators. You have to put, very fine amounts. The jawline, it's amazing for the jawline. Great for the temples and the, nasolabial folds because of the longevity. So remember, the vehicle goes away and then you only have the biostimulatory effect. Now, of course, with any biostimulatory filler, you have to be an advanced injector. So you actually have to know how to use the cannula. You need to know how to put very small amounts, how to, make sure that your injection technique is really delicate. Because if you put a large blob, you're in the wrong plane. You don't know how to use your cannula. If you're using a biostimulatory filler, you're going to be in trouble because you'll get granulomas.
So speaking about needles and cannulas, which size do you prefer, and which delivery technique do you use? Micro aliquot or like linear threading?
So when I'm doing eye boost, it's micro aliquot. I use a mesotherapy needle. I use the invisible needle, and I do micro aliquots, and I'm giving
20 microdots needle.
The TSK needle, it's the invisible needle, it's 33G, okay? But when I am, if I'm using Redensity 2, I will tend to use a 25G cannula, 38 millimeter. Anything finer caliber than 25 is a needle. It behaves like a needle. So between 22 and 25, you're fine. But my workhorse is a 25 millimeter, 25 gauge, 38 millimeter TSK Steriglide.
Okay. Doctor, your entry point, some people enter from here, some people enter from here and do like a fanning in this manner, if you can see me in the camera. Some people place the needle like this and do a linear threading. Which your preferable point of entry?
It just depends on anatomy. So if they have a bit of a malar mound, I don't actually want to go through the malar mound, then I will enter from here and I will fan like this. If they don't have a malar mound, I actually prefer entering from here, because if they have a mid-cheek groove, it allows me, you see this whole movement, it allows me to do a whole sweep, and then I also do the temple and I do the lateral cheek. So it's one injection point. So I'm really looking if they have a malar mound. If they have a malar mound, then I'm not going to go from here this way. Then I'm going to go in the mid-cheek groove and fan this way.
Okay, is it possible to do like epithelial punctures along the tear trough line in this area?
Punctures along the tear trough. I like doing a 3-point technique. Again, I don't know, I'm going to plug my app here. Noury, I have an app. It's a virtual reality app. It's called the OculoFacialAestheticAcademy app. And you have me on tap. I'm showing you cadaver anatomy. So detailed cadaveric dissections. So you join me in the lab. I'm also showing you how you can use hyaluronidase to dissolve filler, to manage vascular occlusions, retrobulbar, supratrochlear, sort of how you would, do the injections. And you also join me in clinic where I'm injecting a chubby face, a slim face, a male face, and I'm using different portfolios so that you can actually see, how to use these different portfolios.
how to use such a technique for a certain case. It's
Yeah,
like customizing each technique for people. Doctor,
exactly.
speaking about your cadaver training program, the OFA Academy, tell me more because I think this is an amazing work. I have seen a lot of beautiful reviews on the YouTube channel. I have seen Dr. Ruth Brady itself. I had an eye opener with her, if you noticed,
Yeah,
and
Dr.
she
Ruth
was
is one
also
of our faculty, but she
yeah.
came
I
on
sent her
as
my regards.
she came on as a trainee, loved it, attended all 3 courses, then came back again. And I said to her, look, she's so lovely and enthusiastic, and she has a wealth of knowledge. I said, why don't you join us faculty? But she came as a trainee first. And essentially, we run cadaver anatomy where we are teaching you dissect cadavers, you see the anatomy, you experience the anatomy. But because we are severely restricted by the number of labs that are available to us in UK. And I wanted my overseas people, because I train a lot of people from all over the world. I wanted them to access the lab virtually. This is why what I did is I set up a virtual reality app. Now, it's on your phone, so you can see it in 2D, you can see it two-dimensional, or you just need a small VR headset. You get them for £10, on Google. Those Google Cardboard VR headsets. You just put your phone in it. You need a good Wi-Fi or internet connectivity. If you buy the app, then you have 23 videos. It's a 12-month subscription. You can keep going back to them, learning from them. There's every time, and the reviews I've had is every time people go back, they learn something new, because the first time you see it, you're paying attention to something, then you start practicing, and then you listen to something else. And once you finish all 23 videos, there is a multiple choice questionnaire, and once you do it, you get a CPD certificate.
Doctor, this training program is like for the whole face. It's not like just restricted to the teardrop area.
The whole face. It's temples, cheeks, jawline, male face, female face, nasolabial folds, lips, the whole thing.
And it's possible also for other people from other countries to join this training program since it's like virtual and it's on an
Exactly.
application.
Exactly.
Exactly. Can I post the link for the
Yes,
website and the
I,
YouTube channel so our audience here in Egypt they may participate? I highly encourage everyone to go or to the OFA Academy.
thank you so much. So we have a YouTube channel, and the YouTube channel is free. And we have guest speakers. In fact, I did this in lockdown. So we have guest speakers who come and speak. I had actually a teardrop masterclass, which is not visible now on it because it was very detailed. So we just do premieres where I'm giving, very high-tech information. But then there are lots of videos on OFA, YouTube, which is completely free. And I have international speakers, they talk on business, they talk on facial overfill syndrome, on the mid face. And I just recorded something with Ruth where we were talking lips. But when you buy the OFA app, now that's the virtual reality app, and I'll send you the link afterwards, Noury. I'd be grateful if you could tell people about it. That app is only me teaching, and there are 23 videos, and then we will update once we are out of lockdown where we can go back into the lab, because currently we can't even go back into the lab. We will
Hopefully, this works.
update and upload more videos.
Thank you, Dr. Sabrina, for your time and for indulging us with your knowledge and experience. You are one of the leading aesthetic reconstructive oculoplastic surgeon in UK. And I guess I added to my CV since this is your first live webinar on Facebook and it was with me. So it's a great honor and pleasure. Just brief.
I'm so grateful to you for supporting me and telling me how to do it, because you were very patient with me, and it's an honor. I love Egypt. I visited
And we
once,
love you too. And
it was
where did you?
fantastic.
Yeah, you
I
came
went
to
to
Cairo?
Cairo and Luxor. And if you follow me, I mean, I'm going to do a post when you send me this video. I'm actually going to do a post of me on the camel with all my headgear. So I
And I hope
loved
when this
Cairo
crisis
and
ends up, you will
Luxor.
be able to visit us in Egypt as a speaker on a conference or a course. I'm sure that a lot of people will be able to learn from you. Reaching the end of our webinar, what advices do you give for dentists who want to practice facial aesthetics?
So, there are certain safe areas to practice. This is a consensus opinion. Greg Goodman and Stephen Liu have written a consensus paper. If you're starting out, start off from an area of comfort. Okay, so the safer zones are the lower face, and then you come to, lateral to this lateral canthal line of the mid face. And then as you come to the tear trough and the nose, this becomes higher risk. Okay, so pace yourself, train, learn at every opportunity. And Noury is doing an amazing job where, he's giving out free education and practice. But take it slow. You cannot become an expert or an advanced technique injector overnight. So, when you see people doing this, don't get tempted with, just going out there and trying it, because complications can ruin a reputation, and reputation takes a long time to build. So take it slow. It's a long race. Educate yourself well, and you'll be amazed at how beautifully you'll do and how your practice will go, because happy patients bring you lots of patients by word of mouth, and you don't spend on the marketing. So get it right, get your model right in the beginning.
Those are Dr. Sabrina, our expert advice. Thank you so much, Dr. Sabrina, for your time and for your effort. It was a great pleasure and honor to have you in this webinar. I hope we can make it all over and over again whenever you are free. Thank you so much for your time, and good night, Dr. Sabrina. تصبحوا على خير ويا رب تكونوا كلكم استفدتوا. Goodbye, Dr. Sabrina. Bye bye.